Good afternoon. Thank you for attending today's event entitled Living and Working with Kidney Disease, Treatment and Accommodations. I am your host, Teresa Thorne, one of the site managers of the Detroit Renaissance District of Michigan Rehabilitation Services. Next slide. Just some housekeeping tips. The question and answer box will be available for questions. Please put your questions or comments in the question and answer box. We highly encourage everyone to utilize the Q&A feature during the presentation to ask questions that can be addressed by our team behind the scenes. And we will respond to as many questions as we have time for at the end of the presentation. Closed captioning is available by selecting the CC closed caption button and then show subtitle. Next slide, please. Zoom offers information regarding the accessible features of their platform, and please see the web link. If you are unable to access the Q&A with assistive technology during the presentation, please utilize the resource information provided following the training to address your question. Next slide. So our presenters today are Mrs. Cynthia Nichols-Jackson, Program Coordinator for the National Kidney Foundation of Michigan, and Ms. Angela Blanchard, Occupational Therapist from Business Network Division of Michigan Rehabilitation Services. We will begin with Ms. Nichols-Jackson.
Good afternoon. Thank you so much for having me today. I am, as mentioned, a program coordinator for the National Kidney Foundation of Michigan. I'm also a patient myself, a kidney patient myself, as well as a master's degree nurse. I like to start with my story. So as I said, I am a patient. So 34 years ago, I was diagnosed with lupus, systemic lupus. 32 years ago, I then sustained the beginnings of kidney disease. When that happened, my doctors worked with me for over 15 years with various drugs, experimental treatments in order to try to slow the progression of my kidney disease. During that time, I was able to work as a nurse, and I did continue my life as I could before I ended up going on dialysis in 2004. At that time, I stayed on dialysis for a year and a half before my girlfriend graciously gave me one of her kidneys. At that time, I then had a kidney transplant, which was successful. It lasted for 9 years. I then went on to complete my master's degree, but after graduation, once again, I then had problems and the kidney failed. Had to go back on dialysis, and this time I was on dialysis for 5 years before last year during COVID-19, I was able to receive my second kidney transplant. It has been successful. As I said, I'm currently working full-time and I'm being able to have a quality of life. So let's talk about kidneys. Next slide, please. Today, our objectives will be for me to talk about the overview of kidney health and its functions, testing and staging, CKD, which is chronic kidney disease statistics, risk, diabetes and the statistics, hypertension, which is high blood pressure and statistics, treatments, COVID-19, prevention, and programs from National Kidney Foundation of Michigan. Next slide, please. So let's talk about your kidneys. In your body, the kidneys are located in the lower to mid back area. They're somewhat the size of your fist. As you'll see on the right side of the screen, the blood filters from the used blood or blood that has waste products from us into the kidney. It goes through a filtering process, which are these small intricate places that you see with the little red lines and the beige, and you see the yellow arrows. That's where the filtering process goes through. It then returns good, clean blood to us. And then all the waste product then goes to the bladder and you end up urinating that out. Next slide, please. Let's talk about the functions of the kidney. This lady over here is like, what does my kidney do? Well, one, it removes the waste products from our bodies. We breathe in as well as we take in items within our mouth, such as food products, and all these things go within the body system. And then when it uses all it's supposed to, waste products are produced. So the kidneys get rid of waste products. That's the urine. It also balances our water. We're made up of 97% water throughout the whole body and blood system. So it keeps us balanced. It regulates our electrolytes, like our sodiums, our potassiums, etc., things that would be able to keep us to maintain life as it should be. It regulates the blood pressure. There is a hormone within the kidneys that serve to aid to keep the blood pressure at a constant level. And if you have kidney problems, sometimes it's because the hormone in the kidney is failing and it can't keep you regulated. It regulates your red blood cells. That means your blood cells end up being where they're strong, they're red, they are nourished, and you're healthy. But when it has a problem with not being a good, strong red blood cell, we talk about the word anemia. We also, the kidney has a function with your with your bone health, keeping your bones strong. So it works with your calciums and vitamin D's in order to keep your bones strong. So kidney patients tend to be more fragile with their bone health and can have fractures and break easily their bones. So again, those are parts of kidney function. Next slide, please. How do you know whether or not you have kidney problems? Well, first of all, you need to visit your doctor. Second, he needs to draw a blood test as well as have you do a urine sample. This blood test that he will be drawing, the blood test is called eGFR, which is E standing for estimated, and it says glomerular is the G, the F is the function, and the R is the rate. So what it is to test the kidney's function. The urine test then is called an ACR. And what that is going to look at is the protein in your body to see whether or not you are urinating out protein. You should not urinate out protein. So that sample is very valuable to see. If you are, that's telling him that you have the beginning signs of kidney failure. Looking at the chart on the right side of the screen, you'll see stages 1 through 5 there. That is from the blood test, as I spoke earlier, the eGFR. If by chance your blood test comes out where let me go back. Let me say that our kidneys are, say if they're at 100%, perfect kidneys, let's say 100%. When they check your blood, if your blood level then is down to 90% of function for your kidney, that's called stage 1. If it goes down to 89, almost 70%, then that's called stage 2. When you're down to 60 and 50%, now we have 2 different stage 3s. It's mild to moderate when it's stage 3A, meaning that we can still work with you to help you slow that progression, as well as in stage 3B, which is moderate to severe. Now, those are areas, again, there's hope in those areas. Those are the times, like I said earlier, where my doctors were working with me to slow that progression. That's where we talk about exercise, diet, maintaining your drugs for any kind of a risk factor like diabetes or high blood pressure that you have. We want you to actually be able to work on yourself to pay attention to your body. Now, when you get to stage 4, that's a severe. So now we're down between 30 and 15% of your body that has function for your kidney. At that point, there is not any more heroic efforts that are done. It's usually now we need to talk about the serious treatment plan. What are we going to do here? If we're doing a transplant, this is the time to look for a donor. If we're doing dialysis, this is the time to talk about access. Which type of dialysis are you going to do? But this is the time when you're really talking to a nephrologist. Stage 5 is end-stage renal disease. This is when actual treatment has to be done because you cannot live without kidneys. So you either have to be on dialysis, one of the other, either peritoneal or hemodialysis, or have a transplant. Now, there is also the last type of way that you could do treatment is no treatment at all. So that is also a respected treatment. Next slide, please. Who's at risk? Are you at risk? Do you have diabetes? Because diabetes is the #1 cause for kidney disease, whether your doctor tells you about it or not. It is the highest risk for diabetics to have kidney problems. So you want to make sure that you do the right thing. Who's another one? High blood pressure. You know, that's the silent killer. And nobody knows because it doesn't announce itself. It's just quietly there raising itself up. But it's also a #2 reason for kidney disease. Other things are kidney failure that people have had in their families, people that have been on dialysis, you know, grandparents, great-grands, cousins, aunts, parents, siblings. Those are people who, if you have it in your family history, you need to be checked just to monitor yourself. Again, it talks about people that have family histories of diabetics or high blood pressure. Certain ethnicities also. African-American is 3 times more likely to have kidney disease. The Hispanic is 1.5 times. So we're looking at those who are Asian, American Indian. All those ethnicities need to check yourself with your doctor to make sure that kidney disease is not in your lineup. Now, over the age of 60, the kidney itself is getting older. So persons that's over 60 has a higher risk. It does not say that over the age of 60, every person is going to have kidney disease. This is not true. So don't look at it that way, but do know that your kidney is 60 years or older. Next slide, please. So did you know that 1 in 3 adults are at risk for kidney disease? And 1 in 7 adults have a history of kidney disease, but many don't even know it. It's quiet. It doesn't announce itself either until things get to be severe. So early detection and treatments are very, very important. As we said, I've said several times, slow down the progression. That's dealing with trying to do any treatment that it takes to slow the progression of the kidney failure. Kidney disease is now known as the 9th leading cause of death in America. Next slide, please. So this graph here is showing the percentages of the adults over the age of 18 that have kidney disease. As we see here, it looks like the 65 and plus, they're the highest as far as age groups, 38% of them. Looks like women are higher than men, as well as I spoke earlier, Blacks are higher than whites and others. Hispanics is a close one behind. So we see the statistics are real and it's out here. We need to pay attention to how we take care of ourselves so we don't become one of these statistics. Next slide, please. So what is again, I'm reiterating, #1 and #2 causes: diabetes and high blood pressure. And your doctor with diabetes needs to be telling you it's in your path. It doesn't mean that every diabetic is going to have kidney disease. No, it doesn't say everyone that has high blood pressure is going to have kidney disease. No, but these are the two, and I will show you in slides to come. I'll show you why. Next slide, please. So diabetes, again, is the #1 cause of the failure, and it's because those small filtering areas that I spoke about earlier that's in the kidney, those are really, really tiny blood vessels. So when high blood sugars are around those vessels, they become narrow and clogged. They also, that high blood sugar will then actually erode or break through those vessels tissue and then cause those areas to die. So that's how small areas of our kidneys, it dies over time. So you want to make sure that you take care of your diabetes so that won't occur. Now, another thing I spoke about earlier is that urine sample. When the proteins, again, they come through, all the waste products come through. Protein is a very, very important mineral that we must have within our system to live properly and strong. Protein should not be spilling out of our urine, but again, I'll show that the protein, which is called albumin, is another name for it, passes through the kidney filters, just like I spoke earlier. And when that protein starts coming through and gets into that urine, those are the early signs of kidney damage. That's why your blood, going to your doctor, getting blood tests and urine tests is so very important. So with diabetes, remember, take your medicine as you should, whether it be insulin or pills. Make sure that you do some diet changes in moderation. Also get some exercise, monitor yourself and get that A1C lab. Do what you need to do to maintain your good controlled diabetes. Next slide, please. Because diabetic patients now, again, like I said, that chronic kidney disease is in your picture. 1 in 3 persons that have diabetes may have chronic kidney disease. So you want to make sure, and that's for both type 1 and type 2 patients. So make sure that when you go to your doctor that it's regular, keep up with your health, get those blood tests, the eGFR, that'll check your function of your kidneys, as well as that urine test to see whether or not you spill a protein. If at any given time you spill protein in your urine one time, every urine from that day forward, you will spill protein. The body will not reconcile itself where you will not continue to spill it. It means that the kidney damage is enough where the protein will always slide through, always slide through. So do know that. Also, again, like I said, keep up with your health, keep up with your doctor's visits and get the treatments and tests that you need to get to stay well. Next slide, please. Let's talk about pressure. It's saying high blood pressure here, but let's talk about normal blood pressure. Normal blood pressure is the blood flow that's coming through the artery. As you can see in the chart next to you, the flow of the blood coming through, that's going to cause some pressure. It's coming through pretty quickly. So as you see these blue arrows pushing against those vessels or that vessel, that's the pressure. Now, when it comes to labeling it, high or low, is due to the force and the rate of the heartbeat. So as your heartbeat, that's the flow of how fast the blood is going. If the beat is harder and quicker, it's going to make it more and more and more where it's beating against that vessel. Now, when it is any movement in there, the elasticity of the vein or artery is very important. When it starts to get hard, now the pressure goes higher because it's more difficult for the blood flow to come through. So remember, the high blood pressure is the second cause of kidney failure. Next slide, please. In the statistics here, we see the high blood pressure on the right. You'll see in the chart, high blood pressure is 26% of the people have, and it can cause kidney damage, 26%. Now, diabetes is at 38%. So both of these health challenges, diabetes being a disease as well as high blood pressure being a disease, both of these show how high they are and how much they are causing the second rate and first rates of why you have chronic kidney disease. You see on here, there's other things such as glomerulonephritis, other causes. I had the glomerulonephritis because lupus is more of an autoimmune disease. So the lupus is what was causing the kidney failure for myself. Again, remembering high blood pressure is a silent killer. Take that medicine, monitor that blood pressure, watch that salt, stop smoking, and do some exercise. Visit your doctors regularly. You can maintain to slow down that progression of kidney disease. Next slide, please. So again, as I spoke about progression, you start with 100%, you're normal. You get into an increase in risk when things start to change in your health, such as diabetes enters your health or high blood pressure. Now it's starting to have a little bit, you spill a little bit of protein here. You're getting into this increased risk. You're African-American. You're going through, all of a sudden the kidney damage is happening because things weren't really checked well when it was an increase. Now we got the damage. So now you're in the stage 3. 3A and 3B. These are areas, again, where I speak about we can work with you with this. We can get you to have your change in life so that you can slow your progression. If by chance the progression continues till we get to the point of stage 4, this is when we need to talk about the treatment plan for what's going to happen, whether it be dialysis or transplant. This is when you ask people, can you help me to be a donor for me for a kidney transplant? Or you get on the list in order to try to wait for a cadaver transplant. When you get into kidney failure, now you're actually either on dialysis or a transplant. In this point where the kidney has totally failed. And when they say the kidney, they being both, they work as a pair, the pair work together. So if one is failing, the other is failing at the same rate. It doesn't come where it's like one is working and the other isn't. That's not true. So it's as one, although we can live with just one kidney. So kidney failure, again, the treatment would be transplant or dialysis. Next slide, please. So you choose your treatment plan, whether or not, whichever dialysis or transplant. Dialysis has 2 different forms of it. Most people have heard of going to a center in order to have hemodialysis, and that works with your blood, meaning that it takes out the dirty blood, goes through this machine and filters it, brings back the clean blood to you. That's done 3 times a week. Or you can choose where it says home hemodialysis, go home, do it at a shorter time for more days during the week, but it's more of a closer to a more natural way that we take care of our eliminations. And it can be done, but have a caregiver to help work with you with that. You can do peritoneal dialysis, where this is to work with collecting the waste products come within the abdominal space. They actually put in a catheter, or a stoma or opening into your abdomen, and you put a catheter in, fill yourself with the solution, empty the solution. It's a process that can be done. A lot of people choose this for more freedom to work. As you see on the left side, the chart here is trying to say, okay, everyone in this picture would have chronic kidney disease. How do you choose whether or not you come out and you do hemodialysis? And although it's spelled different in this slide, this is the European spelling, but it's still hemodialysis. So you see, it can be hemodialysis. They can go from, from hemodialysis to transplant or back, such as myself. I went from dialysis to getting a transplant. It failed. I had to come back to hemodialysis. I now have gone back to kidney transplant. And the same works either way with the peritoneal, hemodialysis, kidney transplant. all in the cycle as you see the arrows flowing. Next slide, please. So what's the goal? The goal is to slow the decline of the kidney function, keep your blood pressure under control, keep your diabetes under control, take your meds, do what you're supposed to do. The things that's risk for cardiovascular or heart disease and problems: stop smoking, exercise more, weight reduction, working with your physician about that. If your cholesterol is elevated, take the medication or work with your doctor about that. Stop taking those over-the-counter pain medication like Advil, ibuprofen. Those are now seen to be a problem with the kidney function. So work at getting pain control another way, speaking with your doctor so that you can get the pain control but not damage your kidneys in the process. Also manage any problems that does come up as kidneys do start to decline. You get into swelling, get into anemia, again, that bone health disorders, those calciums you need to take. Monitor those electrolytes, especially like your potassium and phosphorus, sodium. Know your labs so that you can know how to adjust your lifestyle accordingly, and visit your doctor regularly so you can keep up. Again, this is all silent as far as kidney disease, so labs are how you will tell what's going on with your function. Next slide, please. So 2019, 2020, we got hit with COVID-19. Now, coronavirus is a virus that's already been out there. It's just the name of an actual virus. And COVID-19 is specified because it was a different strain. Now, when COVID first came out, a lot of people were running into problems with breathing. So it was a respiratory thought. But later they started to see more people with kidney disease or just having patients that have kidney failure and having to start dialysis. So then it was looked at as that the COVID virus itself was either hitting the kidney directly and damaging it, causing the person to have instant kidney failure, or it got into the blood system, started clotting the blood, and then the blood clots go around, and to get little blood clots to go through those fine, small vessels in the kidneys, it was just damaging them. So people went on dialysis. Some people were told that they may have had some kidney problems happening prior to COVID that they may have not known. Again, you can't tell if you have problems with your kidneys unless you have blood tests. So people that have problems with diabetes, high blood pressure, heart disease, all these people, as well as even any kidney patients, remember our immune systems are challenged. We don't have a good army to fight off anything as damaging as that coronavirus. So that's why we got really hit hard, and you're still quite vulnerable. Next slide, please. So as you saw before in how they introduced this to us, that the COVID-19 virus was hitting us systemically, by fevers and fatigue. It got into the respiratory, people got into shortness of breath. The circulatory system had no fight because the white blood cells was just really low. This is where the clotting system started, where it was then getting in and changing the flow of our blood to clots. It went into the kidney, it decreased the function. It killed the kidney in a lot of people. Next slide, please. So what the killing I'm speaking about is called acute kidney injury. And acute kidney injury could happen in a normal day, not with COVID, but it could happen where you could have been in an accident or a fight or some kind of trauma to cause damage to the kidney. If it was, a blow to the back and it actually damaged it. It can be blood clots if you're prone to having blood clots on as a disease process, then that also can cause the kidney to shut down, cause an acute kidney injury. Also, if people have kidney stones that are very large, it can get into the kidney, those small little areas, again, causing kidney damage. But those are normal ways that the acute kidney injury diagnosis has been used before. This time, COVID-19 actually attacked the kidney, shutting it down, as I spoke on earlier. And it made it where, again, people were looking for respiratory problems with COVID virus, but here, the kidney itself was being attacked directly, causing the problem, hospitalizations again. Now, they said that some people may have had that kidney problems before and just didn't know it. But they do know that those who were hospitalized afterwards, they may have kidney problems in their future. So they need to maintain regular visits with their doctor to see how it's going. Next slide, please. So what do we need to do for coronavirus? Mask up, wash your hands 6 feet, do that, social distancing, take the vaccine. We as kidney patients, we don't have enough of an immune system to fight off the coronavirus. We don't have it. We don't have it for the common cold. We don't have it for the flu. It's just, we don't have it. We have less of our immune system to be able to fight off big germs. So take the vaccines, take the flu shots, because we need additional ammunition to help our army, our immune system. So take it, please. Next slide, please. So now our programs that we offer for you at the National Kidney Foundation, there are definitely things that can help you. Next slide, please. We have distance learning. Since we can't do face-to-face, we have distance learning programs through via Zoom. We have something called Walk with Ease. It is a walking program that we talk with your counselor that you would be selected with, and how to use walking alone and monitoring yourself and reporting back to them. We have diabetic prevention programs, people that have been told that they are borderline diabetics. This is a program for you that you and your doctor talk about and come in for a year-long program that's very supportive and help you change your lifestyle and keep you from becoming a diabetic. We have something called PATH, or Personal Action Towards Health. This is a self-management program that helps persons with chronic diseases, kidney included, to be able to problem solve, decision-making, health communications, diet, exercise, maintaining your medications. How do you organize your life to maintain a good, healthy life? This is a 6 to 8 week program, and it's very, very beneficial. We have it again in something called Better Choices, Better Health. That's offered more to those who are in remote areas that can receive the same kind of kidney path or other path programs. We have an exercise program for fall prevention called Matter of Balance. And this is again done by via Zoom, but very, very effective. We have a way that someone goes with you. They'll teach you how to shop in your store for your food items, reading labels and making sure that you understand how to keep your diet going. To register for these, you'll see the website below as well as the phone number. Next slide, please. We also have programs for patients. If you are in the problems with a little financial issue, we have a fund that can issue you at least $100 in an emergency. We have peer mentors, those patients such as myself who was adjusted to the life that we have to live, who can talk to you and walk with you and help support you as you go through in the beginning, as well as anytime. We have internships, small ones if people want to return back to work. We can do that. If you have, we have scholarships if you want to return to school. We have a small fund for that. Kids camp, We have that, and we have medical ID tags. People need to wear ID tag after they've had the surgery or on dialysis to let someone know in case of an emergency, you can't speak for yourself. I think this is the end of my session. So next slide, please. Thank you. I will now hand it over to Belinda for her to be able to tell you about the occupational therapy.
Well, thank you so much, Cynthia. My name is Angela Blanchard, and I'm going to be, yeah.
I'm sorry.
Yes, I know. No worries. So I'm going to be talking about kidney disease and reasonable accommodation and some of the services offered by Michigan Rehabilitation Services. Next slide. And again, thank you to Cynthia for that wonderful, very informative presentation on the medical aspect of kidney disease. Like Cynthia, I did want to start with a personal story. So when I was asked to do this presentation, I didn't realize how actually emotionally it would hit me. My significant other, who is a lifelong Detroiter, born and raised, he lost his father when he was 6 years old to the effects of kidney failure due to his father also had lupus, an autoimmune disease. And he, of course, was very young when he lost his father. So this has caused a lot of pain throughout his life and his mother's life. And the way he describes his father was that he was not only a young man, he was 42 when he passed away, but he was tenacious in trying to leave a legacy behind for his wife and young son, including going back to college and trying to work multiple jobs sometimes, this one gets me emotionally, instill all those life lessons with his son, who again was only 6. So trying to teach him how to be a man and leave a legacy behind. And I find myself admiring this man that I've never met. So that became pretty personal for me. Next slide, please. So I wanted to piggyback off something that Cynthia was talking about in terms of the disproportionate effects of kidney disease and kidney failure on various races and ethnicities. And I wanted to share with you some information that I had learned when looking into this, because I found it somewhat disturbing, though not surprising. And when Teresa Thorne had asked me to do the presentation, we were talking about why does it seem like in the city, there's a dialysis clinic popping up on every corner. And as Cynthia mentioned, African Americans, the Hispanic population, and American Indians or Native Americans are at a higher risk than the white population for developing kidney failure. And while African Americans make up 13% of the population, they account for 35% of people with kidney failure in the United States. And compared to non-Hispanics, Hispanics are almost 1.3 times more likely to be diagnosed with kidney failure, while American Indians, Native Americans are about 1.2 times more likely to be diagnosed with kidney failure. So I started looking into this. Next slide, please. And I found some interesting information that I wanted to share with you in terms of racial disparities in diagnosing kidney medicine. So the information started anecdotally at first, historically, that there was talk of higher rates of kidney disease in the African American population, but it started to show up in the medical literature in about 1982. And this risk is due in part, as Cynthia had mentioned, to higher rates of diabetes and high blood pressure in the African American community. So efforts to combat kidney disease was focusing on biology and genetics, those pre-existing conditions, as well as inequality in terms of access to insurance, medical care that can lead to delayed diagnosis and faster progression of kidney disease. Next slide. But there was something else as well that I had stumbled upon. So if you remember Cynthia talking about the GFR, glomerular filtration rate, the eGFR, which is a simplified tool that doctors use to diagnose kidney disease. Now, diagnosing kidney disease is complex. So this is just one tool or a shortcut to estimate something called creatinine in the blood, which is a waste product that everyone has in their blood. And so what I had found was there was actually a race adjustment being used in diagnostics, saying, here is the normal range, or EGFR, for the African American population, and here's the normal range for everyone else. It would even show up on lab reports. Now, this is problematic in a lot of ways, as you might imagine, and it has changed. So I just wanted to talk about why it's problematic and how it has changed. So it was based on a study that found that African Americans had on average higher creatinine in their blood. But this study, looking back, is somewhat faulty, and it looks like they didn't study a high enough, they didn't have enough sample or a sample size of the study. So they were using a race adjustment as a shortcut tool. And this is problematic because it was based on people self-identifying. And so if somebody is multiracial, I watched a TED Talk on this, and this Harvard professor, this woman said, well, I self-identify as a Black female, but I have a white father and a Black mother. So she said, for social purposes, that's the box that I check. But which one is for my kidneys and my genetics? Which box do I check? So there was no guidance for individuals who identify as multiracial. And then, of course, the Human Genome Project shows us that humans are 99.9% genetically similar. And so race is more of a social construct, not a biological construct. And that concept has been heavily adopted now. So the bottom line is there was a risk that individuals in the African American community may not be receiving a timely and accurate diagnosis, or perhaps the severity of the disease progression was not being recognized, and therefore there could be a failure to intervene or provide effective, timely treatment to reduce the progression of the disease. And so just last year in 2020, the National Kidney Foundation and American Society of Nephrology formed a joint task force to review the use of race in EGFR calculations. And they came up with a new way of measuring the GFR or diagnosing kidney disease that is more accurate and not using that race adjustment. So that just took effect last month in 2021, so September 2021. So I wanted to share that with you, not to cause anybody despair, but to show you that we are on top of things in the news and we are paying attention. And if we don't tell these truths, we run the risk of, basically like contributing to this problem. Next slide, please. Additionally, I found this on a Harvard Health blog, and they can say it better than I can. So I'm just going to read it to you. While we now understand more about the genetics and biology of kidney disease in African Americans, they play a relatively minor role in their excess risk. Social determinants of health, race, and racism are equally, if not more important, in explaining the excess risk of kidney disease in African Americans relative to white Americans. These disparate health outcomes are indelibly linked to decades of social and economic injustice rooted in racism, the legacy of Jim Crow segregation laws, unfair housing laws, the redlining of communities of color, separate and unequal education systems, environmental racism, and unfair criminal justice system, and the list goes on. So again, think of it like a pie chart, and things like biology, genetics, pre-existing conditions, lifestyle, diet, smoking, all of those things are very important, but we also can't ignore this sort of elephant in the room, and we have to tell the truth about it. So, all right, next slide, please. So why else are we here? So we're here to increase knowledge and awareness of employment barriers, resources, and solutions for individuals with kidney disease. And we are here to learn about the Americans with Disabilities Act, understanding of Michigan Rehabilitation Services, how we can help individuals who are running into employment barriers, understanding reasonable accommodation as it applies to the workplace and our job seekers who are looking to work while perhaps on dialysis or dealing with other issues related to kidney disease. And lastly, promoting the idea that individuals with chronic kidney disease can and do work. Next slide, please. And this is the MRS mission and vision. So we have a mission to develop a customized workforce solution for businesses and individuals with disabilities. And our vision here is a diverse and inclusive workforce that unites businesses and individuals with disabilities towards a common good. Next slide. So let's talk a little bit about the Americans with Disabilities Act. So that the ADA was passed in 1990. So that made 2020 the 30th anniversary of the passing of the ADA. However, the celebration has continued into 2021 because of the coronavirus. So we are celebrating that still. And how does the Americans with Disabilities Act fit into what we're talking about today? Next slide, please. So the ADA prohibits discrimination against people with disabilities in several areas, including employment, which is what we most frequently utilize the ADA for, and also transportation. Of course, this is very important when talking about employment, public accommodations, communications, and access to state and local government programs and services. Now, as it relates to employment, Title I of the ADA protects the rights of both employees and job seekers. Next slide. So what is a disability? Well, it's important to remember that this is a legal definition rather than a medical one when we're talking about the Americans with Disabilities Act. But basically, the ADA defines a person with a disability as someone who has a physical or a mental impairment that substantially limits one or more major life activities. So what are those major life activities? Well, working is definitely one of them, but otherwise it's like your activities of daily living, like eating, sleeping, grooming, relationships, working, caring for yourself, caring for your children or your loved ones, and as well as it includes people who have a record of such an impairment, even if they do not currently have a disability. So what does that look like? So perhaps somebody that had been in a car accident and previously had some, impairments from that accident, but now they have improved. So they are no longer in the state that they were before. But sometimes we get stuck in this idea of somebody as having a disability or say like a cancer that's now in remission. So they're protected under the ADA as well. Next slide, please. And the ADA also includes individuals who do not have a disability, but are regarded as having a disability. And it also makes it unlawful to discriminate against a person based on that person's association with a person with a disability. I can give you an example there. Say there's a promotion coming up and the boss thinks of a candidate who's a father of 3 and 2 of his children are on the autism spectrum. And he says, gosh, that guy has a lot on his plate. So I don't think he's going to be ready for this promotion. I don't want to put all that responsibility on him when his children have disabilities. And so in effect, that's discriminating against somebody based on their association with a person with a disability. So that is unlawful as well. Next slide. So when talking about disability, it's important to discuss the difference between visible disabilities versus invisible disabilities. A visible disability might be something where an individual is required to use an assistive device like a wheelchair, a walker, a cane. Hidden disability or invisible disability might involve pain that's hidden, fatigue, dizziness, cognitive disorders, brain injuries. Have you ever been, at the mall or the grocery store and you saw somebody park in an accessible parking space and then got out of the car and, walked into the building and you thought, well, my goodness, that person doesn't look like they have a disability. So why are they parking in that space? Perhaps we jump to a little bit of judgment. That's a common thing that we all have done and all do. And yet perhaps that person has COPD, and maybe they need to park closer to be able to walk into the building. Or they have an autoimmune disease, and maybe this is a good day, so to speak, and they've had other bad days. It might be their first day out in a while. So it's important for us to remember to develop compassion for our fellow human beings and not rush to judgment. Next slide. So reviewing this list of hidden disabilities, we had already talked a little bit about some conditions that are related to kidney disease. So kidney disease itself, or end-stage renal, is frequently a hidden disability, as well as diabetes can be a hidden disability, cardiovascular condition, lupus or autoimmune diseases, chronic fatigue. And then oftentimes when individuals are dealing with chronic conditions, something like depression can develop. Symptoms consistent with depression can develop, or other mental health challenges due to all the challenges involved in dealing with chronic health issues. Next slide. So let's talk about employment and reasonable accommodation. Next slide. So first of all, are individuals with kidney disease and end-stage renal disease employed? Well, yes, they are. Approximately, as we know, 90% of people with kidney disease don't even know they have it. So they're walking around, going about their daily lives, working, not even knowing they may have it, including, and this is kind of surprising, 2 in 5 people with severe disease. So where that employment rate starts to kind of drop off is towards the later stages of chronic kidney disease into end-stage renal disease and individuals on dialysis. There was a study of a 13-year study of 18 to 54-year-olds, that bulk of the workforce age, that estimated about 24% are employed at the onset of dialysis. And that's a decrease from 38% 6 months before end-stage renal disease. And as you can imagine, being on dialysis or needing dialysis can present a lot of barriers to employment. But again, that's why we are here to talk about these things, and that's why we're here to help. Another study found that it's not too much different across the rest of the world. In Finland, about 33% of individuals on dialysis reported that they were employed, and India, about 30%. Next slide, please. So what are the factors affecting employment? Well, if the individual was employed prior to dialysis, then they are more likely to continue working after dialysis if they are able to. If they have a higher level of skill or education, they may have more options in terms of jobs, especially some less physically demanding jobs or white collar type of jobs that may offer more flexible scheduling, health insurance benefits, paid time off, FMLA, things like that. And the salary is a factor. If an individual was making a salary that is quite a bit greater than what they would make by accepting disability benefits, then they're more likely to want to continue to earn that salary. But their beliefs and their attitude, if they and everyone around them is saying, no, you're not going to be able to work, just, take the benefits, take the money and run kind of thing, they may be less likely to believe that they can work, or just think that it's going to be possible for them, or maybe think that it's going to be too hard. Likewise, if you have a support system or a significant other that is encouraging you and helping you manage some of those barriers, then the individual is more likely to be employed. And additionally, the type of dialysis, whether it's in-center dialysis or nocturnal dialysis versus peritoneal dialysis, that can affect whether somebody feels that they are able to work or are able to work. Next slide. So where does reasonable accommodation come into play? And first of all, what is a reasonable accommodation? According to the Department of Labor, a job accommodation is an adjustment to a job or work environment that makes it possible for an individual with a disability to perform their job duties. Accommodations may include specialized equipment, modifications to the work environment, or adjustments to work schedules or responsibilities. And it's important to remember that not all people with disabilities, or even all people with the same disability, are going to need an accommodation in the first place, or are going to need the exact same accommodation. We try to take a customized approach because every individual is different. The way that the illness might present may be different. The barriers may be different, and even the essential functions of the job that they are doing would be different than somebody else's. So taking that customized approach to make sure we're putting forth a recommendation for a reasonable accommodation that really fits the person. And businesses of 15 or more employees are legally required to provide reasonable accommodation. So it is the law. Of course, what may be reasonable to Ford or GM, a huge corporation, may be less reasonable to a small mom and pop operation. Again, that's why MRS is here to help and support both our businesses and our individuals as they navigate this process. Next slide. So here are some tips for implementing reasonable accommodation. As a job seeker and counselor, you first want to research the business and research the reasonable accommodation process before you and your customer start working. A business may or may not have a reasonable accommodation process. We do advise that they do, but some businesses have a formal process in place, some do not. And sometimes even when the process is in place, our business customers do need some assistance navigating this process. Discuss disclosure and increase comfortability. So essentially, when you request a reasonable accommodation, the customer is disclosing that they do have a disability. Now, they don't have to tell the employer, what it is and the nitty-gritty details of everything, but you can ask for a reasonable accommodation, and therefore you are on some level disclosing that you have that you have a disability. And the more we talk about that and how to go about that, become more comfortable, our customers can get past some of those fears that are very understandable when going through this process. It's important to know reasonable accommodation will not completely eliminate barriers. It's something that we refer to as leveling the playing field, or helping to reduce those barriers, but it may not, again, completely eliminate them. The goal here is for the individual to be able to perform the essential functions of the job, those main functions. They may not be able to perform all of the marginal functions, and we'll get to that in a little bit. And then you want to implement accommodations one at a time and make it manageable. So some resources for businesses and customers include askjan.org and askearn.org, which can help you with the reasonable accommodation process and even some specific suggestions. But MRS is also a great resource for that. That is what we do, so we can help you too. Next slide, please. So often the accommodation process, it's a mindset or a thought process, because again, we're taking a customized approach here. So starting from left to right here on the screen, we might look at how we can provide assistive technology. Sometimes it's high tech, sometimes it's low tech. Technology example might be a specialized headset or Dragon Naturally Speaking speech dictation software, screen magnification software. Then we kind of look at adjusting or modifying training material, test material. Does somebody need something in large print? Do they need an interpreter during meetings? Acquiring or modifying equipment. Something like, do they need a scooter to be able to navigate the building from the parking lot all the way up to the 5th floor of their office, or some kind of other mobility device? What about modifying the work schedule? there's a lot of talk right now about hybrid schedules and working from home, and that can be an accommodation as well as modifying breaks. Job restructuring may come into play if somebody is able to do essential functions of a job, but maybe not some marginal functions of a job. Take an office assistant, for example. They might be excellent at working the front desk and doing all of those requirements, but it could be difficult for them to ambulate downstairs to go get the mail, which might be more of a marginal function. Can you trade that off with another employee with their consent? That's the important part, with the other person's agreement. Now, if you have somebody that says, well, you know, I want to work as an office assistant, but I don't answer phones, I'm not able to type, filing's going to be a problem. Then we start to get into that area. It's sort of like a last resort where we start to look at how can we reassign this person? Can we upskill this person into a different role within the company? Or do we need to go back and look at a different job for them? So an example of that could be a nurse who sustains a back injury while working in the hospital. And it might become very problematic for her to do a physical job, but she has all this skill set and expertise in the area of nursing. Can we transfer that? And she could become a nurse educator or work in a school or a setting that's less physically demanding. So there's always that option as well. Next slide. So when we look at accommodating kidney disease, well, what exactly are we accommodating here? Typically, it's going to be the effects of the condition. So fatigue, decreased stamina, dizziness, nausea, pain, mental health and depression, difficulty concentrating, maybe swelling of the feet and ankles or edema, and shortness of breath. And let's go on and talk about some case studies. And I want you to put your, your OT hat on and start thinking about some reasonable accommodations. So Aki is 48 years old with diabetes and recently diagnosed kidney disease, estimated to be at stage 3A. So she works in IT for an automotive supplier in an enclosed office. And in the documentation, she states that she wakes up frequently at night to go to the bathroom. Most mornings she feels incredibly tired, as if she just worked 40 hours and it's only Monday. She has noticed swelling in her hands and feet, and she has back pain that she says gets worse with sitting too long. So what barriers might Aki face? If you're starting to think of how the fatigue, pain, and swelling may be affecting her, perhaps stamina, performance, productivity, the accuracy of her work, mood, morale, attendance, and frequent sick days. And so what could we put in place to potentially accommodate Aki? So we could offer an alternative break schedule, place a cot in her enclosed office. Perhaps she may need to lie down for 15 minutes at a time instead of taking an hour lunch. Have a flexible schedule, maybe work from home a few days, get an ergonomic chair, supportive chair for her, a footrest or footstool to elevate her legs, maybe a sit to stand desk to change positions, speech to text software. And then energy conservation strategies, those are important. A lot of times we find that sometimes somebody's morning routine might be so hectic, they've got to get up, get showered, pack the lunches, get the kids off to school, that we start to look at how can you conserve energy in the morning so you'll have more energy for work. Can you take your shower at night? Can somebody else take on the driving the kids to school? And then a bedside commode. This wouldn't fall under the employers to provide their responsibility to provide this, but MRS could potentially step in and provide equipment such as a bedside commode to help her at night when she's up frequently to use the bathroom. Next slide. And I do want to save time for Q&A here. So I'm just about at the end here, but case study number 2, Greg is a 56-year-old male with end-stage renal disease on continuous ambulatory peritoneal dialysis, or CAPD. He is the manager of a chain variety store like a Dollar General, And he reports decreased balance, decreased mobility, issues with stair climbing, decreased sensation, neuropathy in his feet, decreased endurance during activities of daily living due to the effects of dialysis treatment, and decreased verbal memory. So what barriers might Greg face? Well, if you're thinking of the neuropathy and the balance deficits, he might be at risk for falls, mobility issues, stair climbing difficulty may affect him in his home. Even just to do his ADLs, bathing, dressing, medical management, decreased stamina may be affecting his productivity. His attendance may suffer, or he may become forgetful of verbal interactions with customers, staff, and his boss. Next slide, please. And so what are some potential accommodations? Maybe a mobility device or a scooter, flexible break time, and a private area for him to administer his treatment. Maybe we're breaking up those break times again throughout the day, because he does have to perform the peritoneal dialysis 3 to 5 times a day. So at least 1 or 2 times will be at work. Use of a wall calendar, a day planner, setting alarms on his phone. His boss could send him text messages or written instructions in place of verbal commands, so he's more likely to have something to reference if he forgets. And lastly, those energy conservation strategies. So I think let's skip the last case study and we'll go right to Q&A. Does anybody have any questions?
Thank you, Cynthia and Angela. There are a couple of questions in the Q&A box that I think are geared towards Cynthia.
I saw that, so I went to looking them up. So
Okay.
the first one was, can you read that one to me? Because I did my
I
answer.
sure can.
Thank you.
If someone chooses not to receive treatment, what is their life expectancy?
So this is something that could happen. The life expectancy is per individual, but because you cannot live without kidneys, it can be a matter of days or even several weeks. It is recommended, if this is your choice though, they ask for you to speak with your physician, the social worker, and they will counsel you on, is this an abrupt thought? Is this something you thought all the way through? Maybe psychiatric counseling might come into play, where it might be a depression thought, but a hospice will be discussed, as well as palliative care. So it's not just you decided that you want to stop in, so tomorrow you're gone. It doesn't say that. But it also says you still have support systems within your team that will be with you. Okay.
Thank you.
You're welcome.
Another question is, I have a family member that just had their kidneys removed. What is their next step?
So is it one kidney, or I don't believe it's both, because if it was both, you would be asking me about next steps. Next steps, if they had both removed, they would be instantly putting the person on dialysis, because the surgeon wouldn't go with just leaving the patient that way. That's not true. So if it is one kidney, let's go with that assumption, then it is either a dialysis or a transplant. Now, if the person goes on dialysis, whether it be peritoneal or hemo, remember, you always still have the option of transplant. You work with the nephrologist, you can still ask persons to try to donate for you. You can reach out to strangers, all type of tools that are out there for that, as far as asking. But the person does not have to die just because the kidney has been removed. Remember, we can live with one kidney.
So those are the questions that we have. If you have any other questions, please put them in the Q&A. We would love to answer. This is a lot of information, but we felt that this was a topic that needed to be discussed. Like Angela mentioned, it's like an elephant in the room. We don't
It is.
discuss much about this. And you know, within our families as well. Now, I do have a question. So we talked about, you know, maintaining that kidney function. So if you go from 100 to 90% and it's detected, you're like, okay. So you can slow and stop it. Can you regain that 10%, or once it's gone, it's gone?
It's gone. God gave us 100%. That's all we got to work with.
Okay.
Numbers can fluctuate in your lab. So if you took a lab test and say you were 55 one time, which is about a stage 3, and the next time you're like 63, which would put you back in like a stage 2, that's a fluctuation, but that's something to get your attention. That says things are, you know, changing. You're not strong on being just, you know, only 70% of your kidney is left. It's saying, you know, there's some wiggle room there, but it does get your attention. And that's why the importance of to continue watching those labs. And these days, they don't give you that paper like they used to for you to be able to keep pieces of paper and monitor who you were 6 months ago and who are you today. So the patient portal is something you have to keep up with, and it's a bit more challenging, but it is something that you would need to keep up with your own lab results in order to know, again, when was the last time you tested it? Because if you're not talking about it till when you go in and you got a cold, or, you know, it's just the annual time and he hasn't tested you for your kidney function in 2 years and you didn't notice it. The next time, you know, he's telling you, we need to start talking about dialysis. You're going to be furious. So, you know, it's better for you to keep involved with your health. And professional health professionals tell us as nurses to promote patients to keep in touch with their physicians because they want to know, who are you when you're not sick and dire? Who are you? Because when you walk in there, when you're sick and dire after that, they are Johnny on the spot. They want to help you anyway. How? When you have investment in your health and you can talk about, I did this, this, and this the correct way, and I got more questions, they are there. They will talk to you beyond 15 minutes. They want to get into you. They want to help you. They want you to become a team member. So I encourage the relationship between you and the health provider, keep it going and keep it well. And if that provider is not trustworthy, move down the street.
Very true.
All right, thank you.
I second that.
Yeah.
Okay, so we have another question. Back to the Kidney Foundation presentation. Is a low sodium diet a suitable recommendation for someone with kidney disease, and how effective can this diet be supportive?
Supportive. So it is recommended that you watch your sodium level. It's usually about 2,000 milligrams that you can have in a given day for a normal human being. It depends. If you are a dialysis patient, remember when you get dialysis, sodium, potassium, and different minerals are added to the bath of the kidney formula to release that waste product from your body and return back to you the proper minerals that you need. So a lower sodium diet, if you've been told that, try to get a nutritionalist or a dietitian to work with you so you'll know your level for your labs and your life, and be able to talk about foods that you can eat or not eat, so then you could be able to do a better job of maintaining your system. So sodium is important. Okay.
Thank you. We probably have a little less than a minute, and there are no other questions. Tyler, if you can go to the last couple of slides. So these are some resources. Thank you. And we just want to say thank you to our panelists, Cynthia Nichols-Jackson and Angela Blanchard, for providing their knowledge during today's sessions. And we also want to thank our American Sign Language interpreters, Deborah and Belinda, for their service as well. I appreciate you all for attending. And if you would like more information, please speak to your MRS counselor. If you do not have an MRS counselor and would like to learn about services, please contact Ms. Linda Tooks. And here's her email address and her phone number. So if you could take a screenshot, that would be great. Once again, I thank you for attending, and hopefully everyone learned a little bit more about chronic kidney disease. Thank you.
Thank you. Thank you. Thank you. Bye now.
Bye-bye.